Okay, so I'll go ahead and get started. So again, really appreciate the opportunity. My name is Brian Kemper. I'm the Senior Vice President of Enterprise Solutions for OneDrop.
Okay.
Is it okay to go ahead and start, Marian?
This is perfect timing. Thank you, Brian, for starting.
Perfect. So
everyone should be tuned in.
Excellent. So really appreciate the opportunity again to provide a quick overview of OneDrop's program. If you go to the next slide, Michelle. So for those that don't know OneDrop, we've been in market since 2015. We started on the direct-to-consumer side, initially with a free version of our mobile app. We were global from day one. So today we have a full multinational program powered by over 3 million users on the platform. We very quickly built out a holistic digital diabetes program. So we started in diabetes. And in fact, we're the first ever ADA recognized digital program available in the market. That full program today is available in over 30 countries. And as I said, we initially launched with the free version of our mobile app, and that was very intentional. We have since then amassed over 15 billion longitudinal health data points that we use to power OneDrop's AI-powered predictive insights. Next slide. So as I mentioned, we started direct to consumer. The idea there was we felt like if we could deliver such a compelling offering that consumers would be willing to pay out of pocket, that would set a very high bar compared to other programs. So really within the last 2 years, we've now brought that proven program directly to employers. And really our differentiator is AI-powered self-care. So it's a holistic, personalized multi-condition program. It's not 4 programs for the 4 conditions that we cover, being prediabetes, diabetes, high cholesterol, high blood pressure. It is one program that's configured to the individual based on their 1 or more conditions. So we include connected devices, the mobile app, a robust educational experience. Every participant is assigned a dedicated coach and has unlimited one-on-one personal coaching. And then of course we provide turnkey implementation to make it easy for our employers. Next slide. So as I said, our big differentiator is our AI-powered insights. So when we first launched our glucose predictions back in 2018, it was at the American Diabetes Association annual conference. And what we showed for a large group of people with type 2 diabetes is we could not only provide a glucose forecast out to 12 hours in the future, but we could do it accurately enough that it was considered clinically significant. And so what that really does is it encourages people to stay engaged in their day-to-day self-management, to understand not where they are, but where they're going, and allow them to make healthy decisions to stay within their target range. So we went back out, asked people whether or not this provided value, and the feedback has been overwhelmingly positive. Go to the next slide. And so in addition to those really differentiated capabilities, we started investing in clinical studies to prove that our program delivers results. So over the last 3+ years, we've shown consistently for diabetes, we can lower A1C by at least 1%, increase in physical activity levels, increase in healthier eating as measured by fewer carbs per meal, really good engagement based on per participant per week interactions, good NPS scores. Now we're over 20 peer-reviewed published studies. And of course, all of those clinical outcomes lead to cost savings over time. Next slide. So in summary, we really believe OneDrop's approach is a new way forward. Again, highly personalized AI-powered self-care. It's a whole person approach for those conditions that we cover. Our predictive insights are now informed by over 15 billion health data points from the over 3 million users on our platform. It's one of the few multinational programs available in over 30+ countries. And again, we've invested to show that our program delivers results based on our peer-reviewed studies. So thank you so much for the opportunity to share an overview of OneDrop. For those interested, my contact information is here, and feel free to reach out to me directly or through our website. Thank you very much.
And thank you, Brian, and thank you for supporting this program. We really appreciate that.
Absolutely.
Let me just mention this coming session, before I turn it over to Mary Carol to do the real introduction. This mental health is near and dear to my heart. Mike Thompson is leading, one of the leaders of the Path Forward. We've talked about that in several of our meetings. Our participation in Dallas-Fort Worth Business Group on Health is a major player in rolling the Path Forward in mental health and substance use. Andy Keller is also a good partner in this. We do many things with the Meadows Mental Health Policy Institute, which is also sponsoring this event, as well as Blue Cross Blue Shield, which partners with us on mental health. This mental health has moved to the front burner for all of our employers, and COVID, as the title of this session suggests, is the catalyst for many of the enhanced strategies to support a mentally healthy workforce. So with that, let me invite Mary Carol Hicks, who is our serves on our board of directors and is chair of our programs committee, and has brought these. She and her committee has brought these sessions to us, the topics to cover. She is the benefits manager at Texas Instruments. Mary Carol, it's all yours.
Thank you very much, Marianne. Thanks for everybody being here. Good afternoon. I am pleased to introduce our speakers. We'll start with Michael Thompson. He's the president and CEO of the National Alliance of Healthcare Purchaser Coalition, the only nonprofit purchaser-led organization with a national and regional structure dedicated to driving health and healthcare value across the country. Prior to joining the National Alliance, Mike was a principal at PricewaterhouseCoopers for 20 years. He's a nationally recognized thought leader for business health strategies and health system reform. Mike has worked with major employers and other stakeholders on sustainable cost reduction, integrated health, wellness and consumerism, retiree health, private health exchanges, and health reform. Andy Keller is President and Chief Executive Officer, and Linda Perryman Evans, Presidential Chair of the Meadows Mental Health Policy Institute, a Texas-based nonprofit that provides nonpartisan policy and program research, development, and advice to state and local leaders towards a single goal: improving mental health care delivery in Texas. Andy's a licensed psychologist with more than 20 years of experience in behavioral health policy, financing, and best practices. His work has centered on helping state and local health systems implement evidence-based and innovative care, as well as helping local and state governments develop the regulatory and financial frameworks to support them. Last but not least, Sharon McClure knows Texas healthcare. A native Texan and proud Texas A&M University graduate, she leads healthcare delivery operations for Blue Cross and Blue Shield of Texas, which offers the broadest provider network in the state, covering all 254 counties. Having represented mental health plans, physician organizations, and hospitals prior to her tenure at Blue Cross, Cher's unwavering commitment to both improve and protect the physical and financial health of Texas has bolstered her reputation as an executive thought leader. Thanks to her wide range of experience in the industry, Cher brings invaluable leadership and expertise to some of Blue Cross Blue Shield's most important business functions. Thank you all so much for being here. I'm really excited to hear what you have to say on this topic. And with that, I will turn it over to y'all.
Well, thank you. So this is Mike Thompson with the National Alliance, and you know, I think I may have met some of you before as it relates to the path forward for mental health and substance use. And some of this is going to sound familiar. I hope it is, because it's very important. You know, mental health has never been more important than during COVID, but the issue around mental health and substance use is not a new issue that, you know, we have been focusing on. We actually think there's been a crisis in mental health and substance use, in a public health crisis, really, and one that employers, frankly, are right in the middle of, around delivering access to high quality care. And the path forward is focused on that. So I'm going to just fly over what that program is focused on and give you somewhat of a perspective on that. So there's really 5 areas that the path forward is focused on, and these areas are all evidence-based, and there's potential issues in all of them. The first one is improving in-network access to behavioral health specialists. We know that this issue exists not just in Texas, but across the country, as being able to get access, timely access, to a behavioral health specialist, particularly if you're a new patient. And we hear from employers all the time, plan sponsors all the time, that this is an issue that needs to be addressed and one that we're looking to deal with. The second issue is measurement-based care. Measurement-based care is what it sounds like. It means taking the temperature of your mental health using standardized instruments that have been proven that if they're used, you will identify treatment issues earlier. You can treat earlier, which means they'll be less serious when you do treat them. And then secondly, if it's used during the course of treatment, you'll end up getting the treatment right more often. In fact, it improves outcomes 20 to 60%. So that the fact that that is not the standard of care today in terms of what's typically done in the mental health profession or in primary care for that matter is a major concern. The third and very important component of this is the issue of collaborative care or integrating mental health into primary care. Most mental health medications, behavioral health medications, are administered through primary care. Most mental health presents itself in primary care, but the quality of the care that is provided is uneven, either because the primary care physician is uncomfortable in dealing with it, or they deal with it and don't follow with it, or aren't as guided in how to do it. The collaborative care model is, again, I think it has over 70 studies that be proven as a very effective model for improving care in primary care, not just sending it out to specialists, but it also, if issues do require triage to specialists, it is a natural way to triage to the right level of care depending on the issue. And so you'll hear more about that, I'm sure, from the other speakers as well. But this is a key element of improving access for employees and their families. The next area is telebehavioral health, which frankly has been a priority even pre-COVID. And COVID has actually opened up the doors to telebehavioral health like never before. It's actually exploded. A lot of the barriers to telebehavioral health have come down during COVID, and one of the key issues is keeping those barriers down post-COVID, and making sure that we are getting it right. We are starting to promulgate standards and issues around, what is high quality telebehavioral health. And again, a lot of employers and plan sponsors have implemented telebehavioral health during this period, but sometimes not necessarily with as much focus and guidance as being a core part of their strategy. And I think going forward, this will remain a core part of our mental health strategies. And then, of course, reducing legacy behavioral health disparities. And access is only one part of that. And sometimes the issues behind the access relate to the issues of disparities on how we're treating mental health versus other types of treatment, parity type issues. So more to come there. Next slide. So again, those are the 5 issues. What's important to think about is that those issues independently are important, but together they actually are very synergistic and support each other. We don't have enough specialists to meet the demand for mental health services really anywhere. I mean, we don't, and with that in mind, those specialists are not practicing in network. So first, we need to find a way to mitigate and use those specialists more effectively, more efficiently. And if we could have more care delivered more effectively in primary care, that would mitigate those issues. Turns out telebehavioral health has turned out to be a way to attract more providers into the system, the network system, if you will. And it has also been a very efficient way for providers to provide care, and it can be equally effective. So very positive. So again, we see these as multidimensional, but also mutually supportive. Next slide. So why should we care? Well, obviously we care about the health and well-being of our workforce at its core, right? I mean, people are the core of our business. This is an emerging issue. It's always been an issue. It affects the significant percentage of the population, and that percentage has gone up somewhere between 60% and 100% during COVID. So, but this is not an issue that goes away when COVID goes away. We had an issue before COVID. It's only been exacerbated during COVID, and we need to sustain change here. But what the Milliman study showed is that not only is it impacting your mental health costs, it's impacting all of your costs. In fact, the most expensive 10% of patients with a mental health condition account for 70% of annual total healthcare costs. And the majority of those, or the 10% that accounted for 70% of your annual, the majority of those, or the top 10%, had both a physical and mental health condition 57% of the time. Finally, the part that is kind of stunning is even when we identify people as having a behavioral health issue, a condition, and they're coded as such, we find an incredibly low amount of spend for half of those people with that condition, meaning $95 per year. So they've been diagnosed with a mental health condition, and they're only spending $95 a year. Well, that means that we've effectively not, again, there may be different stories in that 50%, but it means we're under treating as well, right? We're throwing a drug at it and then it's going away and we don't pay any more attention to it. So we have a lot of work to do to improve our ability to provide better care, follow-up care, and produce outcomes. And we know that if we get the mental health right as part of that broader version, of total person health, we will mitigate other costs that will more than pay for the small incremental costs that we might see on the mental health side. Next slide. So the reason for the path forward is the need to enable systemic change in the system. And oftentimes it's very difficult for any of the stakeholders to move it. The plans are often concerned that the providers aren't engaging. They don't want to join networks, right? The plans themselves might only have less than 10% market share. Some of the Blues bigger numbers than that, but it's rare that somebody has most of the market share in any market. And we know that how we as purchasers or we as benefit consultants influence the purchase of healthcare matters. That if we are out there buying discounts on the basis that, oh, clearly we have people in the network, well, it turns out you can't assume that if you can't get appointments. And so that is one of the key issues that we need to address. And so we're bringing these stakeholders together. And if you go to the next slide, we're doing it systematically. We have a steering committee of kind of partner organizations, the coalitions, National Alliance of Healthcare Purchaser Coalitions, the HR Policy Association. So that is the association of the heads of HR, the CHROs of Fortune 500 companies. I think they have 400 of the 500 Fortune 500 companies. So many of your bosses belong to the HR Policy Association. They have determined that mental health is a top 3 issue for CHROs of Fortune 500 companies. And they are strongly advocating and supporting the path forward for mental health and substance use. The American Psychiatric Association, they know that there's a problem, and they know they need to be part of that solution, and they're at the table helping us. The APA Center for Workplace Mental Health, Bowman Family Foundation, and Andy Keller with the Meadows Mental Health Policy Institute right there in Texas, which is, Andy's been a core partner on this right from the very beginning, along with the APA and the National Alliance. But key to this implementation is to not just do it with a series of white papers and explaining what we think the problems are, but to actually work those problems at a detailed level regionally. And through that, we're doing that through 8 what we're calling reset regions, regional employer stakeholder engagement teams. And you, Dallas-Fort Worth, together with the Houston Business Group on Health, are one of those reset regions. And if you go to the next slide, again, I mentioned the HR Policy Association. They represent those Fortune 500 companies. Next slide. If you go to this slide, you see that we have 8 reset regions, and these represent some of our biggest, most successful coalitions in the country. California with the Pacific Business Group on Health, and Silicon Valley Employers Forum, Florida, Kansas, Mid-Atlantic, Minnesota, New York City Metro, Tennessee, Texas. All of these are somewhat different situations. You know, healthcare by its nature is regional, is local, and to get relevant, you've got to be on the ground and have those relationships regionally. And that's what our path forward will be doing in these 8 reset regions. We'll also be sharing across these regions, and we are engaging with the national players on this. So all of the national players have been engaged with to participate, but obviously the local blues are always one of the most critical stakeholders in the game for the path forward, and as well as other local plans as well. So go to the next slide. Again, there's a lot of things that makes this unique. It's really the only national behavioral health implementation plan in this area. What's been interesting, as we've engaged with the health plans, there isn't one health plan that didn't say, yep, those are the issues. Yep, that's the issues. The employers, it hasn't been hard to get the coalitions on board. You know, these major coalitions that have a zillion things on their agenda, this is one of the top issues on their agenda. We had one Fortune 100 company attend a Mid-Atlantic reset region meeting, and she said, you know, this is 80% of the problems I see is in mental health, and we've got to deal with these issues head up and deal with it together. So again, I think we see this. We also see this as more than just impacting the healthcare for employers and employees and their families, but also it's across the entire thing. There's collaborations going on with the Medicaid programs. Clearly, it has implications for Medicare. We had one of the national plans participate in the Mid-Atlantic reset region call, and they had 4 different people to talk about collaborative care. One representing Medicaid, one representing, you know, that's what we're dealing with. This is very complex, getting people on the same page, moving it together, and then getting that consulting community to support it in the same way, and make this part of the way they're thinking about what value looks like in the mental health arena. Next slide. And what are we looking for? We're not looking for a white paper. We're looking for measurable improvement on metrics that have been established to improve access in network, to improve quality of care, and the adoption of the collaborative care model, improve the adoption of measurement-based care, and enhance the role of telebehavioral health. So all of that is part of our mission here, and what we're signing up together with these stakeholders to do. We're not thinking this is easy. We think we actually have to understand what the issues are that are getting in the way, because I think everybody is well-intentioned here. But the outcome is not where it needs to be, and we need to move this together. So that's where we're going to be. Next slide. So with that, I'm going to turn it over to whoever's next, and I'm sure we'll have some questions later.
Thank you, Mike. And now it's Andy. Tell us about what's local.
Well, thanks. And thanks, Mike. And, you know, it's been great to be part of the partnership. Mike and I met about just over 2.5 years ago, where I came to talk about Texas, and he came to talk about the nation, and we had the same talking points, and we said, we probably better work together. So, because this isn't just Texas, this is America, and in some degrees the world, but America specifically around how we've organized healthcare. If you could go to the next slide, please. You know, the Institute, I'm not going to talk too much about us, but we're a nonprofit policy research organization. And, you know, we work on policy, state, local, national policy, but a lot of the state policies that drive this issue are the ones Mike talked about. They're policies that are set by employers and health systems and regulators. And, you know, the issue is everybody's kind of conspired. Nobody can control the whole thing, as Mike just explained. So it's really tricky. We got to get everybody to kind of shift at the same time. While at the same time, we also need to work in these local regions and local systems. And that's what I'm going to talk about is our local work in the Dallas-Fort Worth area in partnership with Mary Ann and the Business Group on Health and the employers there. I'm probably going to focus a little bit more, though, on what needs to change in health systems. Because y'all, as purchasers, can only purchase healthcare that's actually delivered. And Shar can only have in her networks providers that actually do things. So we have to have providers at the end of the day make these changes. So if you go to the next slide, I want to talk a little bit though about the context for this, because Mike talked about how we need this more than ever with COVID, but I just want to put some numbers on here that I really want you to think about. Right now, last week, or 2 weeks ago, before Thanksgiving, and I'm thinking it's worse now since none of us were allowed to travel over Thanksgiving, symptoms of clinical anxiety using the GAD-2, which is a clinical instrument, 85% reliable, are up fourfold from last year. 36% of Americans are suffering from clinical levels of anxiety. 27% of Americans, a fourfold increase from last year, are suffering from clinical levels of depression as evidenced by the PHQ-2. Now, these are a little fuzzy, but these are the same measures year over year. And these are just startling numbers. And I don't think this is a surprise, but I think it's sometimes hard to fathom exactly what this means. The number of people considering suicide is double what it was last year. And we don't know how many people are dying from suicide because unlike metrics for COVID, which are updated daily, or sometimes like multiple times a day, we update our metrics on suicide every 2 years. So 2 years from now, we're going to know how many people died from suicide in Texas in 2020. 2022 is when we're going to know. And there's folks working to speed that up. We have a little bit better surveillance around overdose deaths, which I think you've seen in the papers lately, have definitely been up. So we know that folks are suffering, and it's children. And we also know, too, that people with mental illness are 65% more likely to contract COVID based on a recent study in The Lancet, which got a lot of attention about 1 in 5 people develop mental illness after having COVID. It really wasn't what that said. It's like 6%. Other people already had mental illness, so they just have recurrences because of COVID. But the bigger thing is 65% of people getting COVID have mental illness. 65%, I'm sorry, not 65% higher risk profile, to get that data right. So this is a big deal, bigger now than ever. If we go to the next slide, we've done some trending on this, and it's being picked up nationally. But if we go to the next, this underlying, I'm going to kind of speed to the next slide if we could, the one that's a graph. This underlying epidemic, which predated COVID, and between suicide and overdose, we lost over 120,000 Americans in 2018, which again is the most recent year we have data for, is expected to go up probably by 15 to 20,000 people this year. So yeah, it's not the same number of people dying as dying from COVID, but it's an underlying pandemic that is being exacerbated. And you all as healthcare purchasers, if you get your healthcare provider partners to go along, have a big role to potentially play in that. So let's skip forward down 2 slides, if you would, to the Cloudbreak slide, because I want to talk about the Cloudbreak initiative. And this is what we call the on-the-ground work here in North Texas that we do in partnership with UT Southwestern's O'Donnell Brain Institute, the Center for Depression Care and Research, Clinical Care and Research there with Dr. Madhukar Trivedi. We've been partnering on this for 2 years, thanks to the generosity of Dee Dee Rose and the Rose family, which funded this. And now we have the Meadows Foundation and other funders. AT&T recently put in some funds to help with this, coming together to really try to turn the tide and help North Texas be the first place that frees everyone from the scourge of depression who suffers from that in North Texas each year. So let's talk about what that means. Next slide, please. As Mike showed you, there's a lot of pieces that need to be connected, and he kind of showed you the 5 kind of policy levers, but we also need to connect that on the ground here in North Texas between purchasers, providers, communities, everyone coming together to do this differently. Next slide, please. And this is the vision. The vision is to eliminate untreated depression, because right now, only about 1 in 18 people who have depression actually get connected to effective care. And that's not okay. And it doesn't mean we can help everybody. It doesn't mean everybody's going to get better. But if we just did the 2 things Mike talked about, measurement-based care and collaborative care, empowered by telehealth, we would be able to save potentially 1/6 to 1/3 of the number of people who would otherwise die from suicide in North Texas if we had universal access to that based on our modeling. So next slide. I'm going to talk about some numbers that you know pretty well, but I want you to think about them a little bit differently. So we know a lot of people get depression, and I'm just focusing on depression because of the specific ties into the pandemic. Now, we know the path forward is going to help all mental health needs and substance use disorder needs through the interventions that are there. But if we just center on depression, about 1.5 million Texans a year have depression. And keep that in mind, 2 million Texans a year have diabetes. And I love that we had one drop being able to be at the beginning talking about their measurement-based tool for monitoring your diabetes status. What if we had that for mental illness? And the tools Mike talked about that we have are not only not in the hands of consumers, they're not being used by most clinicians, which I think is actually hard for most people to believe. Most people probably would expect their psychiatrists and psychologists and social workers to measure symptoms. The reality is most are not. When I was trained in the early 90s, we were actually told not to focus too much on symptoms because we would reduce people's motivation to change. I mean, think how messed up that is. So you've got generations of mental health clinicians needing to be, I guess, become woke to the modern practice of medicine in a person-centered way. That's 125,000 adults and 25,000 children in North Texas. I'm sorry, just in Dallas County alone. And so that's really what we're trying to do. If we can make Dallas County, and we're happy to have Fort Worth compete, be the first county in the world to offer help to everybody with depression by first finding them through measurement-based care, joining them in their journey by having ongoing measurement-based care, and then providing collaborative care and more specialized care for those with more severe conditions. So next slide, please. Actually, I'm going to jump over this one because I want to talk a little bit about how we're moving this forward. Then we'll jump over this one too. You know that there's a lot of stuff, and Mike hit a lot of this earlier. So there's the barriers that Mike talked about at policy level, but there's also barriers in the treatment setting. Stigma, we're not going to bring it up. And if we do bring it up, we're not necessarily going to know how to talk about it. And that includes clinicians don't want to bring it up. We miss it. 8 to 10 years post-symptom onset is when we get people diagnosed and treated. Obviously, access to care, affordable care is important. That's why coverage in Medicaid is just as important in the commercial world, but we need it in the commercial world too, not just in Medicaid. And then access to treatment and being able to make it there. And that's really where collaborative care becomes becomes important. I don't know, there's some word I had in my head. This has been happening to me more, Mike, lately as I get grayer with my hair. Next slide, please. So what we're trying to do then is take 4 prongs of approach. 1 prong focused on clinical systems, 1 prong focused on smart purchasing, which is what Mike talked about with the path forward. 1 prong talked about community, which is pulling the community together, which is another really important part of the path forward. And then research, because we do think the research component is important because we have to have hope because we don't have cures for everybody right now. We have a lot of folks who we lose and we will continue to lose. But you know, just because we lose the vast majority of people who have pancreatic cancer, doesn't mean we don't screen for it and try to help them and be with them and do our best. And that's what we have failed to do for, frankly, every mental illness, and what we're trying to help North Texas be the first place in the country to no longer fail to do for people with depression. Next slide, please. To focus a little bit on the clinical system piece, the implementation of those things that Mike talked about, and not just that, also linkages to our specialists, because we have to empower those frontline. That's an important part of collaborative care. Collaborative care doesn't just help you in primary care, it also creates a referral pathway and the infrastructure to get you to specialists when you need them, and then get you back for your ongoing care, and to coordinate with your broader care of what I like to call the neck down physical health, thinking of mental health as the neck up physical health. So what Collaborate's doing is really partnering with the 12 leading health systems in North Texas. We're really excited because the Meadows Foundation just made a $1 million grant that we're going to use to actually provide incentives to health systems to retool. It's not rocket science. They just need to update their electronic health records to include measurement-based care. They need to redo some workflows. They need to hire and reposition some people using telehealth, which is the best way to do it for collaborative care. But health systems have about 1 million things they need to do, and now they have one huge one in addition, which is to cope with COVID. So getting this bumped up the priority list among health system leaders and empowering them both through funds, but also through the recognition that a prestigious grant from the Meadows Foundation can provide, is a big part of what we're trying to do to collaborate. And we're hoping to announce the first health system in early 2021. And if you want to help us encourage some of the health systems that serve your members, please let us know. We think we know who the finalists are, but we haven't made the decision yet. Next slide, please. The smart purchasing piece, I'm going to skip over that because Mike talked about it, but let's talk a little bit about what the community piece looks like. The community side is really important because we have to change the general expectation. It's not going to be enough to just have better healthcare available, more evidence-based healthcare. We really have to help people understand and know that they can do that. So I have people all the time ask me, Andy, where do we go for help? And I'll tell them that maybe you do need to see a psychiatrist, but why don't we start first with your primary care doctor? Because that's really where you're going to get your healthcare over time. And we need to be asking them. And, you know, I have some physician friends who say, well, the primary care doctors I know, they don't want to do this. And I said, Well, that may be, but most of them actually are doing this now. 50% of the care, as Mike said, is happening in primary care. And so let's help them do it better. Let's actually put a behaviorist in the primary care setting generally through telehealth, in a collaborative care framework, so they're not having to do this alone, and they can actually do things other than just medication and actually use the right medications, which is would be a nice thing if they did. So let's go to the next slide. And actually one more after that, because I talked a little bit about the research before, and I think this is the concluding slide, the next one after this. I got excited on my slides. This is sort of the bottom line. There's a lot of wonky things we need to do. There's a lot of technical things we need to do. There's a lot of things we need to do differently in care that frankly we know how to do. It's just the will to do them. But what we really need to do is summon the will. We have to believe that we can do this. And that's why I love this quote that came from one of the stakeholders when we put this together, that we have to hold that belief that ending depression is just as important as ending other healthcare issues. And if we don't do that, we're leaving millions of our fellow Texans, of our family members, and in some cases, and many of us ourselves, alone. And we can't do that anymore. And we can do that big. And if we're not going to be able to do it in Texas, we're not going to be able to do it anywhere. So we need you guys to join us in that. And it's an honor to be a partner of Mike and the Dallas-Fort Worth Business Group of Health with Marianne and everyone. And I think together we are going to be able to do this. And I'm excited, Shara, to hear what you all are going to say, because you guys are a huge partner in this, serving so many North Texans.
Well, thank you, Andy.
Thank you, Andy. Shara, tell us about Blue Cross Blue Shields.
All right, thank you. So first, I want to congratulate Michael and Andy for all the great work that you've done in this space. Blue Cross and Blue Shield of Texas, we are aligned with the Path Forward initiative. We have a long history of working to increase access to care for Texans, and behavioral health is certainly no exception. As you've mentioned, in many ways, 2020 has proven that, behavioral health care has incredible value in our community. Most Texans have experienced or know someone who has experienced some form of depression or anxiety this year. And we believe mental health, like you, requires a holistic approach. The first thing we do, and we want to make sure our members know how to access care when they need it and have the information that they need. We have about 6 million members in Texas that we cover. A little over 5 million of those have access to behavioral health through our network. And in our largest network, we have just over 16,000 behavioral health providers that are actually in network with us and have contracts. Over time, we have relied a little less on some of our third-party mental health vendors, and we took a big step just in 2020, earlier this year, to in-source management and claims processing for one of our largest networks that affected hundreds of thousands of our members. This really enhances our ability to connect with our members and also leverage our medical data along with behavioral health data. And bringing these capabilities in-house, it's really designed to improve care coordination, efficiency, and directory accuracy, which I know is something important for the path forward. Just operationally, just over the past few years, we used to just distribute behavioral health claims among all of our claim processors throughout the state. Now we send them all to one place so that those claim processors are familiar with behavioral health claims and don't have to figure out, go from medical to behavioral health. So we've found that to be efficient and reduce claim processing accuracy. We also have a care management team of licensed medical and behavioral health clinicians, and they're focused on identifying members' comorbid medical and behavioral health conditions. And sometimes this can be a sensitive topic, but if we know that someone's abusing opioids, for example, we might have an opportunity to intervene. In a situation like that, we'll work with providers to manage prescriptions or reach out to the member to offer assistance. And we've also entered into a pilot. It's a pilot project with MAP Health. They're an organization that uses certified peer recovery to help people achieve and sustain long-term recovery from a substance abuse disorder. We've also improved some of our analytics and reporting. This has helped us integrate behavioral health programs with what we call our well-being management program. Well-being management is a whole person approach to care management. It allows us to manage care for members with coexisting chronic or complex conditions. The well-being management program, it identifies opportunities for intervention and really coordinates care between providers. And so let me just talk a little bit about network adequacy, because I think you mentioned that, Mike. We need to make sure that we have enough in-network providers. So we do a lot of adequacy studies, and we do it not only, there's geographic adequacy, meaning how many miles do you have to travel to get a behavioral health professional, access to a behavioral health professional. We also do member to provider ratios, as well as, it's self-reported, but appointment availability studies also help us monitor adequacy. And for our largest network, we find that we exceed 90% or exceed some of the standards of those, but we are still continuing to monitor that and see what we can do to improve our network adequacy, as well as our provider directory accuracy. We recently adopted some policies that allow us to terminate or delete providers that have had no activity, no claims activity, nothing in 24 months. And we expect to begin implementing this data cleanup in early 2021. Next slide, please. So let me touch a little bit. I think we mentioned that you mentioned, Andy, we don't actually provide care, but we do a lot of collaboration and working with our providers. We have, let me give you some examples of some of our provider partnerships. Collaborative care models like the Path Forward, it requires a commitment from our providers, and we support that. We encourage our providers through many of our accountable care organizations to recruit and refer to mental health clinicians who support primary care physicians. And our ACOs and value-based programs are very primary care focused right now. And this helps them make a business case to incorporate mental health practitioners, because they're measured on quality, they're measured on cost, and they're measured on effectiveness. One of the partners, you may have heard of our Sanitas medical centers. This is a great example of collaborative care. These are designed in a way to adhere to the collaborative care model. We work with them. They run 4 advanced primary care medical centers in Dallas County. We have 6 more in Harris County in the Houston area. They're working to integrate behavioral health services, and we support them in many ways. We support them with value-based care contracts that really incentivize them to manage the whole total cost of care and manage all the components of their patients they serve. And we also co-locate customer service in many of those locations, so that our members can access help for their benefits, as well as accessing help for their primary care and urgent care. They're also doing screenings by medical social workers for behavioral health conditions in their offices. Another one of the partners that we work with is a wellness company called Catapult Health. They traditionally visit work sites for physical screenings and have actually pivoted to virtual during COVID-19, and they also help us increase access. They provide mental and behavioral health screenings as part of their annual wellness exam. They use the patient health questionnaire, the PHQ-9 assessment. I think you mentioned the PHQ-2, but this is a simple and validated tool that helps with diagnosing depression. And in just a couple of years ago, after they began including this screening, we actually saw a 40% increase in our claims through them that address depression. So that means that a lot of the people that they were screening were actually accessing care, and it all came from the people who took the PHQ-9. And finally, we've implemented some digital tools. So if individuals, maybe there is a stigma, they might not want to access their behavioral health provider, they want to look to a digital tool. We started offering our members a tool called My Strength, and this is for the first time. It's an app that helps members find way to manage stress. It provides support for emotional health and even tips for parenting during this crazy time. My Strength is available in a COVID-19 specific version. It includes more than 25 education modules about mental health and evidence-based coping skills. These topics range from loneliness to managing time at home with kids. And in total, users can expect a variety of material presented in like short 2 to 3 minute lessons, and they can engage on their own schedule. So we're always evaluating partnerships, both in, with our primary care physicians and in the digital behavioral health space. And we want to approach them with a critical eye to focus on how they can improve clinical outcomes for our members and have a positive impact on our members' health. And we also look for cost-saving opportunities as well. So let's go to the next slide and talk a little bit about telemedicine. So this is a graph, and it just kind of shows over the course of the year. First of the year, we had very few telemedicine claims. Then you come to March, April, when everything is shut down, people can really access for their providers. We saw a huge spike in telehealth claims. And you see the blue line is physical health, and the orange line is for behavioral health telemedicine visits. And so you see that early in the pandemic, all spiked. You saw the telemedicine visits for physical health kind of taper off later, kind of mid-year, a little later in the year. But as you see, the behavioral health claims, they've kind of leveled. They dipped slightly, not as much as the physical health claims, but they've really leveled off. And I think that shows how people are really relying on these behavioral health claims. I mean, the pandemic, it's taken a toll on the mental health of many people. They're feeling stress, anxiety, loneliness, and telehealth is frankly, it's a very easy way for them to access behavioral health services. So we enhance telehealth in two specific ways to make sure our members could access quality, affordable care in their communities. We expanded the types of service that they could be used for, including behavioral health therapy. And of course, we temporarily lifted cost sharing for clinically appropriate medical and behavioral health services that are provided virtually from local providers as well as MD Live. And so we've kind of gotten to know telemedicine as a mode of care delivery, not just a benefit. So this is just, we see this as an alternative method. I think you'll see us continue to support this even after the COVID-19 pandemic or the COVID-19 crisis, because I think that this is just one of the things that we're going to continue to see. And, this, of course, the pandemic drove widespread adoption of telehealth, and it continues to drive within the industry. And so one thing we've seen is we've actually seen practitioners who are no longer keeping an office. They are dedicating their practices to telehealth. So we've got to figure out, how do we monitor adequacy if this care is being delivered virtually instead of like from a mileage standpoint, because many adequacy standards are based on geographic distances. So I think that's something that we're going to continue to have to monitor. So let's go to the next slide. So just some more numbers around telehealth adoption. This spurred rapid adoption by providers and patients. Providers are now seeing 50 to 100 times as many patients by telehealth than before the pandemic. 57% of providers view telehealth more favorably than they did prior to COVID-19. So now that they're trying it, they're actually liking it. 64% of providers are more comfortable using telehealth, and then nationwide, there's been a 4,000% increase in telehealth claims compared to 2019. So let's go to slide 5 and kind of look at these types of visits. So this slide is specifically around professional behavioral claims volume by service month, and you'll see business as usual, January and February. So you've got 3 lines we're looking at. The blue line is face-to-face. You saw that very high earlier in the year, then dropping dramatically and staying relatively low through mid-year at least. You saw telemedicine that started at virtually 0 in the beginning of the year, spiking and then maintaining through mid-year. And then that gray line that barely even registers, those are our vendor behavioral health. So we've got MD Live and vendors they'll treat anxiety, depression. They say that they provide services, and you'll see, even in February, we only saw 1,000 claims per month. That increased substantially in March, April, and May, but it's still very small. Even though those numbers have doubled and tripled, it's very small in comparison to individuals that are accessing behavioral health practitioners. So if we can go to the next slide very quickly. So one of the biggest questions that we get is around payment parity. So there are 2 dimensions of payment parity that I'm gonna discuss. One is payment parity between in-office and virtual, and the second is payment parity between mental health and medical claims. So do providers get paid the same amount if they see a patient in person versus virtually? That depends on whether or not the service is the same virtually as it is in person, and it does get kind of technical. Both the American Medical Association and CMS have looked at this issue, and they created a list of patient-provider virtual interactions that end up having the same outcomes as if they're done in person. We recognize those AMA and CMS identified services as telehealth services. We make them eligible for coverage, and we pay for those services at parity. The same services receive the same payment, and we want to make sure Texans get the care they need, and we want to do our part to lower the cost of care. And as far as mental health parity, Blue Cross's commitment is to comply with laws and regulations that are established about mental health parity. That might be oversimplifying, but what matters most is that we're going to do what's right for our members. And of course, we have many value-based care contracts in place, like I mentioned, with Sanitas, with our primary care accountable care organizations. And for those practices, we reward providers for not only managing the total cost of care as compared to what we're seeing trend in the rest of the market. We're not, rewarding them just for the number of telehealth or in-person visits they have. It's about managing the total cost of care and utilization. So for those practices, savings and efficiency are the focus, and that does provide parity. It's also worth noting we have dedicated resources to make sure we respond to member and provider inquiries quickly. We're committed to transparency, and we even provide educational materials on our website. If you want to go check out those, it's not the most relaxing read for a Sunday afternoon, but we want to make sure the public understands the complex terminology around mental health parity regulations and compliance. Next slide. So in wrapping up, while we're in a good place, as Michael and Andy pointed out, we have a lot of work to do. We see our role as very important in that work. When we look at the collaborative care model, I think we have an opportunity to introduce and encourage this with our primary care physicians and the health systems that we work with to better integrate physical and behavioral health, improve access, and treat the whole person in the populations that we all serve in Texas.
Wow, this is really impressive what you all are doing. Thank you, Mike, and thank you, Andy, and thank you, Shara, for sharing your perspectives. The three are seemingly almost like it's the Russian doll where one piece fits into the other. It's kind of neat to see. And what I'm seeing is that there are multiple dynamics at work here. We've got almost the push-pull, the national effort that's it's taking on, a lot of work and a lot of effort and bringing it all together, and probably won't happen tomorrow, but it's moving, like moving a mountain, and it definitely is beginning to move. And we're very pleased to have Dallas-Fort Worth Business Group on helping a part of that mountain moving process. We need a big bulldozer or something, don't we? Anyway, the earth movers. The other thing that, Andy, you were describing what you're doing in the North Texas area. I'm pleased and proud to say that, again, our employer members, our coalition has been an integral part of the whole process as well, and working with you to make this happen on the employer side. So we appreciate that partnership that we have with you on that, with our Depression Advisory Group that meets periodically, and will begin meeting again after the first of the year. And then, of course, Shara, what Blue Cross Blue Shield is doing is remarkable. I did not know until your presentation today the many different aspects that you're working on that are perfectly aligned with the path forward and with the Meadows Mental Health Policy Institute's Cloud Break initiative. It's such a nice fit. So a couple questions. There were several in the chat box. One of them is the, let's go back to this one. Since the majority, this is an interesting one, since the majority of care for depression is through prescriptions of antidepressants from primary care, through the primary care process, what's being done to help educate primary doctors about precision medicine to identify the right medication at the right time? So whoever wants to take that one.
Well, I can talk about what we're doing in North Texas on that. And I think, first of all, the foundations are the two components of the path forward. Measurement-based care. You have to be documenting symptoms if you're going to have precision-based medicine. I mean, that's sort of a prerequisite. And then the nice thing about collaborative care is it puts the clinician in the behaviorist, rather, in the primary care office virtually or in person. So, they have somebody there who is an expert. So you don't have to have the primary care doc be an expert in everything, and they develop that collaborative frame. So they learn the parts that are best leveraged as the primary care perspective, but then also allow the behaviorists to do the more specialized piece. But, the neat thing that we're doing in partnership with UT Southwestern is the implementation of the Vital Signs 6 suite of measurement. And what the Vital Signs 6 measurement does is it basically takes the entire array of measurements for all the different potential mental health and substance use conditions you can have and pairs them with sort of best practice, sort of what would be the medication to try first, second, third, just as suggestions, just to kind of basically give an aid for the primary care practitioner to think through it and say, huh. And also another little thing about precision medicine is you got to remember to do it. So when you're seeing, hundreds of people a week and, Andy comes back and I had sort of some borderline depression, not quite, but you probably want to talk to me a little bit more closely about that the next year when I come back for my next physical. It provides reminders. So that workflow around precision medicine is just as important as the knowledge base. And that's one thing that the Vital Signs 6 tool and other approaches too, but Vital Signs 6 is a nice way to kind of put that together.
I'll just add in, Marianne, that first of all, I don't think we're any further along on precision medicine here than we are anywhere else. I don't think it's core to, we're trying to walk before we run here, just to get some behavioral health clinician support within there. And again, even those behavioral health practitioners often are not using measurement-based tools. So we're so far from precision medicine. We've got work to do to actually move there. But what is important to recognize is, particularly with things like depression and other mental health conditions, there's a heterogeneity in the effectiveness of medications, that not every medication works for every individual. And it's critical that the plans, the formularies, the PBMs acknowledge that, and that we are committed to kind of getting to the right medication faster. And this is where measurement-based care also comes into play. If it doesn't work all the time, if you are not measuring symptoms at the beginning and during the course of treatment, you will not course correct, because you will assume, well, I gave them a prescription for a medication. I don't know how you practice medicine in behavioral health without being measurement-based, knowing the heterogeneity of how people react to different treatments. And so I just think it's a very important question. I don't think we're quite there yet. Frankly, it's got me thinking, so I appreciate the question.
Yeah, that's interesting. One of the things I was thinking about, Cheryl, when you were describing all the really positive things you're doing through the Blue Cross Blue Shield to really not just to make mental health easier to get to, and much better. Anyway, I was thinking about the physicians, and we're all talking about the primary care setting. In fact, many of our companies, our employer members, are advocating and really engaging in the primary care, advanced primary care. So they're very keenly interested in that aspect. I know you mentioned that you have value-based contracts with incentives for the physicians, but I'm thinking about the screening tool. How challenging is it, or how easy is it, to work with the physician, different practices, to embrace these new ways of dealing with primary care that they may not have been prepared for, even for the total well-being side that the employers are really, really engaged in and pushing? How easy or hard is it to work with them?
Have about 50 or 60,000 physicians, maybe 13, 14,000 primary care physicians throughout the state of Texas. Many of them are part of large integrated systems. Some of them are independent, some are rural, some are, some are in metro areas. So you just have a variety of physicians in the way they practice. We try to encourage them to aggregate their membership so they can participate in population health. But, I think it's important to just kind of meet the providers where they are. Some like Sanita, some in our very sophisticated accountable care organizations. They have those electronic tools. They have those clinical pathways. Others, we have to kind of bring up. It's a matter of just meeting providers where they are and bringing them along in the collaborative care model. And so as long as we design those incentives and make sure that the data is available to the providers and help them understand their opportunities to be successful in these value-based care programs, I think we just want to make sure we're making progress in those areas.
Well,
And Marianne, just to pile, I don't mean to pile on, but it's an important point. You know, integrating mental health into primary care does not need to be done in a co-located way. It can be done virtually.
Yes.
And in fact, the only way this is going to come about at scale is with plug and play solutions that allow primary care physicians to work with somebody that's built the infrastructure. They're not going to build it from scratch, especially if they're a small practice. And the good news is there are these plug and play solutions. And the even better news is those plug and play solutions are growing exponentially today. So I think, you know, I'm optimistic we can do it. Obviously, people would prefer to start with the bigger practices, but we don't serve our rural communities well if we just assume that we're only going to deal with big practices. We've got, how can you provide comprehensive care in a rural community if you don't integrate behavioral health into that primary care practice?
Yeah, so I agree, and I hear what you're saying, and that's one thing that we're trying to do with these rural care, these rural communities, because some of them they have fewer capabilities. However, like you said, we could introduce some of those plug and play solutions so that they can be just as effective as the larger groups. Thank you.
You know, and if I can just add on that too, that's why also these changes need to not happen in isolation, because, you know, no one's going to want to introduce measurement-based screening and tracking if they don't have anything to offer, like if they don't feel they have the skill set or the background. So that's why the collaborative care piece, the strengthening of the telehealth for referrals and integration. I mean, they go hand in hand. I mean, there's no bad guy out there that we just have to do the one thing. Unfortunately, it's super complicated, and we all have to work together on it. And I think that's why it's so, you know, encouraging to hear that, Shara, everything you guys are doing. It's really cool.
It truly is. I'm thinking about, I mean, there are so many things to think about. The rural community not having the access or the high-speed internet access that others do. But I do see from your data that you showed, John, about the telehealth and telebehavioral health, I think this is just going to be just probably the best medicine to come down. And, you know, there aren't many things to think positively about COVID, but I will say that the moving into the virtual world, well, maybe not so great for programs like ours. I'd much rather do this in person, but certainly for treatment, for all kinds of different treatment, diabetes management, just about everything, telehealth. So the next key is for all of us is to convince Congress to, or CMS, or whoever the powers that be, is to reimburse for telehealth adequately in parity with inpatient or in live visits. That's a sticky wicket that's on the docket right now, but I think that's going to be imperative to maintain this capability that we've started with and to continue its progress. We have come to the end of this session. I wish I could ask a gazillion more questions. There's one on mental, on reducing the stigma, and there's just a whole lot of different avenues we can go down, but we'll have to save that for another virtual meeting perhaps, and maybe next year in person. So thank you, Shara, so much for participating. I'm proud of what you're doing and proud to be associated with Blue Cross Blue Shield and the things they're doing, and as well as the other plans that are doing similar things in this community. We're grateful to have those partnerships. And thank you, Andy, for what you're doing. Keep pushing that string uphill in the North Texas area, and we're going to be right behind you pushing along. And Mike, thank you for your leadership with Path Forward. It's an important initiative that we all should be really advocating.